keep hearing tissue. Everybody's talking about tissue. Get these grabs, get more tissue. In your approach to a patient who's been newly diagnosed, is there a difference in what you're looking for if the patient's localized versus advanced when you're doing a tissue analysis, and what type of tissue analysis do you do just at baseline? And then if you have, and then what's your wish list?
Yeah. Well, so I think, if you had asked me this a year ago, there was some debate still about next generation sequencing and utility of it and reimbursement of it. But the FDA and the payers have already spoken this year that NGS is indicated and covered in most solid tumors. And part of it is really based on these pan-tumor, solid tumor biomarkers such as MSI and even HER2 in some cases. And one could argue, yes, you should wait until the patient is metastatic to do these testing, but in reality, we all know that a patient with T3N1 tumor will recur, most of them will recur, so it's important to have the roadmap so you can make some decisions early on. So the biomarkers in first-line metastatic setting now is really HER2 is the only biomarker, and in later lines of therapy, MSI and PD-L1 positivity in esophagogastric. For MSI tumors, one would argue that it's very important to know the status from the get-go. Lizzie Smith published the data from the MAGIC study where the MSI tumors, if they received chemotherapy first and then went on to surgery, those patients had significantly lower overall survival than if they went straight to surgery. So all of this argues that we need to know the tumor biology from the get-go. And in metastatic setting, that's even more so. Our metastatic cohort that we recently published, MSI patients don't respond to chemotherapy. They progress within first 3 to 4 months. And, yes, if you're lucky, you can get them to second line, but you really shouldn't, do that. And perhaps we should start thinking about more innovative treatments early on.
Now, let's say you send off your next-gen sequencing panel and it comes back with CDH1. Patient doesn't have any family history. What is your thought there?
Well, so I have the luxury of actually getting immediately both the germline and the somatic, and I think that's where the field is moving. Some of the commercial panels don't look at the germline data. We can send our patients for both, and if the patient opts in, they are the results are revealed. And for these incidental cases where the patient did not sign informed consent to be informed of their germline decision, once again, there's a QC procedure where I'm notified, and then we can have a discussion with the patient as to how they want to handle it.
Gotcha. And Kohei, in Japan, are you doing next-gen sequencing on your advanced patients?
Yes, as a research, but still not reimbursed. But we have a project of NGS testing for GI cancer patient who will receive the chemotherapy. So until now, more than 5,000 patients were enrolled, and we have so many data.
That's a great data set. So, Eric, I'm gonna take us back quite a few years to TOGA and talk a little bit about HER2 and HER2 testing. You mentioned earlier that's a little bit different between breast and gastric. What are your thoughts around this, recommendations around what testing should be ordered?
Well, HER2 testing is important for patients with metastatic disease. I think there is a universal agreement on that. The segment of patients with a HER2 positive tumor, they may benefit from chemo plus trastuzumab. However, this is a relatively small group. In clinical practice, it's usually around 15%. In the initial trial, it was a bit higher, because some tumors were already, some samples were enriched and investigators sent positive samples. But in general, it's 15%. We can do the testing on as well the primary tumor as on the metastasis. In the TOGA study, most of the samples were primary tumors. We need enough biopsies because, as I mentioned, gastric cancer has some differences with breast cancer. The tumor is more heterogeneous for HER2. There is an incomplete membrane staining, so there is a certain training also needed by the pathologist who needs also enough samples. And then if you look at what is recommended is usually that we look at as well immunohistochemistry as FISH testing, and the criteria for reimbursement or for approval are slightly different between the US and in Europe. In Europe, we have more strong HER2 positive patients where trastuzumab has been approved based on the TOGA study. This was a subgroup. In the US, it was like in the trial, the intention to treat, which said patients with immunohistochemistry 3+ and or a positive FISH test in this situation. While in Europe, it's I'd say 3+ or 2+ followed by a positive FISH test. With that difference, the number went down a little bit, and the benefit was a bit bigger. And the hazard ratio in the intention to treat analysis, like in where the label is in the US, was around 0.75, and in the European, the so-called strong HER2 positive was around 0.65. Having said that, HER2 testing should be done in the first line in patients with metastatic disease. And if patient is HER2 positive, based on the criteria that I just defined, then the recommendation is to treat the patient with a doublet, a chemotherapy doublet, a fluoropyrimidine plus a platinum plus trastuzumab. And that segment is there, and that's generally accepted in all different